Nih, kita lanjut untuk yang materi reading guideline GINA. Confirming the diagnosis of asthma in patients already taking ICS containing treatment. If the basis of a patient's diagnosis of asthma has not previously been documented, confirmation with objective testing should be sought. In primary care, the presence of asthma cannot be confirmed in many patients who have previously received this diagnosis. The process for confirming the diagnosis in patient already on ICS containing treatment depends on the patient's symptom and lung function. In some patients, this may include a trial of either a lower or a higher dose of ICS containing treatment. If the diagnosis of asthma cannot be confirmed, refer the patient for expert investigation and diagnosis. For some patients, it may be necessary to step down the ICS containing treatment to confirm the diagnosis of asthma. How to step down ICS containing treatment to help confirm the diagnosis of asthma? First, assess. Document the patient's current status, including asthma symptom control and risk factor, and lung function. If the patient has risk factor for asthma exacerbation, step down treatment only with close supervision. Choose a suitable time when there is no respiratory infection, not going away on vacation, and not pregnant. Provide a written asthma action plan so the patient or caregiver knows how to recognize and respond if symptoms worsen. Ensure they will have enough medication to be able to resume their previous dose if their asthma worsens after stepping down. Second, adjust. Show the patient or caregiver how to reduce their ICS dose by 25 until 50% or stop either maintenance medication like LABA if being used. See step down option in box and schedule a review visit for 2 until 4 weeks. Third, review response. Repeat assessment of asthma control and lung function test in 2 to 4 weeks. If symptoms increase and variable expiratory airflow limitation is confirmed after stepping down treatment, the diagnosis of asthma is confirmed. The patient should be returned to their lowest previous effective treatment. If, after stepping down a low-dose ICS containing treatment, symptoms do not worsen, and there is still no evidence of variable expiratory airflow limitation to confirm the diagnosis of asthma, consider choosing ICS containing treatment and repeating asthma control assessment and lung function tests in 2 until 3 weeks, but follow the patient for at least 12 months. How to make the diagnosis of asthma in other contexts? Patients presenting with persistent cough as the only respiratory symptom. Common cause of an isolated non-productive cough include cough variant asthma, chronic upper airway cough syndrome, often called postnasal drip, cough induced by angiotensin-converting enzyme inhibitors, gastroesophageal reflux, chronic sinusitis, post-infectious cough, inducible laryngeal obstruction, and eosinophilic bronchitis. In cough variant asthma, a persistent cough is the only symptom, or in cough predominant asthma, the most prominent symptom. The cough may be worse at night or with exercise, and in some patients it is productive. Spirometry is usually normal, and the only abnormality in lung function may be airway hyperresponsiveness on bronchial provocation testing. Some patients with cough variant asthma may later develop wheeze and significant bronchodilator responsiveness on spirometry. Most patients with cough variant asthma have sputum eosinophilia, and they may also have elevated FANO. Cough variant asthma must also be distinguished from eosinophilic bronchitis, in which patients have cough and sputum eosinophilia, but normal spirometry and normal airway responsiveness. Treatment of cough variant asthma follows usual recommendation for asthma. Occupational asthma and work exacerbated asthma. Asthma acquired in the workplace is frequently missed. Asthma may be induced or more commonly aggravated by exposure to allergen or other sensitizing agent at work, or sometimes from a single massive exposure. Occupational rhinitis may precede asthma by up to a year, and early diagnosis is essential as persistent exposure is associated with worse outcomes. An estimated 5 to 20% of new cases of adult onset asthma can be attributed to occupational exposure. Adult onset asthma requires a systematic inquiry about work history and exposure, including hobbies. Asking patients whether their symptoms improve when they are away from work, weekends, or in vacation is essential screening question. It is important to confirm the diagnosis of occupational asthma objectively as it may lead to the patient changing their occupation, which may have legal and socio-economic implications. Specialist referral is usually necessary, and frequent PEF monitoring at and away from work is often used to help confirm the diagnosis. There is more information about occupational asthma in section 6. Athletes. The diagnosis of asthma in athletes should be confirmed by lung function test, usually with bronchial provocation testing. Conditions that may either mimic or be associated with asthma, such as rhinitis, laryngeal disorder like inducible laryngeal obstruction, dysfunctional breathing, cardiac condition, and overtraining must be excluded. Pregnant women. Pregnant women and women planning a pregnancy should be asked whether they have asthma so that appropriate advice about asthma management and medication can be given. If the clinical history is consistent with asthma and other diagnoses appear unlikely, but the diagnosis of asthma is not confirmed on initial bronchodilator responsiveness testing, manage has asthma with ICS containing treatment and postpone other diagnostic investigations until after delivery. During pregnancy, bronchial provocation testing is contraindicated and it is not advisable to step down ICS containing treatment. The elderly. Asthma is frequently undiagnosed in the elderly due to poor perception to airflow limitation, acceptance of deep noise being normal in old age, lack of fitness, and reduced physical activity. The presence of multimorbidity also complicates the diagnosis. In a large population-based survey of asthma patients older than 65 years, factors associated with a history of asthma hospitalization included co-diagnosis of COPD, coronary artery disease, depression, diabetes mellitus, and difficulty accessing medication or clinical care because of cost. Symptoms of wheezing, breathlessness, and cough that are worse and exercise or at night can also be caused by cardiovascular disease or left ventricular failure, which are common in this age group. A careful history and physical examination combined with an electrocardiogram and chest X-ray will assist in the diagnosis. Measurement of plasma brain natriuretic polypeptide and assessment of cardiac function with echocardiography may also be helpful. In older people with a history of smoking or biomass fuel exposure, COPD and overlapping asthma and COPD or asthma COPD overlap should be considered. Smokers and ex-smokers. Asthma and COPD may be difficult to distinguish in clinical practice, particularly in older patients and smokers and ex-smokers, and these conditions may overlap asthma COPD overlap. The Global Strategy for Diagnosis, Management, and Prevention of COPD by Goal 2024 defines COPD on the basis of chronic respiratory symptoms, environmental exposure such as smoking or inhalation of toxic particles or gases with confirmation by post-bronchodilator FEV1 per FVC less than 0.7. Clinically important bronchodilator responsiveness more than 12% and more than 200 milliliter is often found in COPD. Low diffusion capacity is more common in COPD than asthma. The history and pattern of symptom and past records can help to distinguish patients with COPD from those with long-standing asthma who have developed persistent airflow limitation. Uncertainty in the diagnosis should prompt early referral for specialist investigation and treatment recommendation as patients with asthma COPD overlap have worse outcome than those with asthma or COPD alone. Obese patient. While asthma is more common in obese than non-obese people, respiratory symptoms associated with obesity can mimic asthma. In obese patients with dyspnea and exertion, it is important to confirm the diagnosis of asthma with objective measurement of variable respiratory airflow limitation. One study found that non-obese patients were just as likely to be overdiagnosed with asthma as obese patients, around 30% in each group. Another study found both over and underdiagnosis of asthma in obese patients. Low and middle income countries. Diagnosis of asthma in low resource setting, including low and middle income countries, presents substantial challenge for clinical practice. Access to lung function testing, particularly spirometry, is often very limited. Even when available, lung function testing may be substantially underused, unaffordable for the patient or health system, or too time consuming in a busy clinic. A single lung function test may not be sufficient to confirm the diagnosis of asthma or indicate an alternative cause, so more than one visit by the patient with resulting cost of time and travel may be needed. The differential diagnosis of asthma in these countries may often include other endemic respiratory disease like tuberculosis, HIV/AIDS, associated lung disease, and parasitic or fungal lung disease. As a result of these issues, clinicians often use a syndromic approach to diagnosis and initial management based on history and clinical findings. Practical evidence-based resources have been developed and implemented in several countries. This approach reduces diagnostic precision but is based on the assumption, valid in most MICs, that underdiagnosis and undertreatment of asthma is more likely than the overdiagnosis and overtreatment often seen in high-income countries. GINA does not recommend that diagnosis of asthma should be solely based on syndromic clinical patterns and suggests lung function testing with a PEF method if spirometry is not available. The World Health Organization packages of essential non-communicable disease intervention for primary care lists the PEF method as an essential tool in the management of chronic respiratory disease. When spirometry is not available, the presence of variable expiratory airflow limitation, including reversibly obstruction, can be confirmed by PEF. For example, before starting long-term ICS containing treatment, the following investigation can help to confirm the diagnosis of asthma or prompt investigation for alternative diagnosis. More than equal to 20% improvement in PEF 15 minutes after giving 2 puffs of albuterol, improvement in symptoms and PEF after a 4 weeks therapeutic trial with ICS-containing treatment. Either of these findings would increase the likelihood of a diagnosis of asthma versus other diagnosis. A structured algorithmic approach to patient presenting with respiratory symptoms forms part of several strategies developed for improving respiratory disease management in LMIC. These strategies are of particular use in countries where, owing to the high prevalence of tuberculosis, large numbers of patients with respiratory symptoms present for assessment at tuberculosis clinics. There is a pressing need for access to affordable diagnostic tools, peak flow meters, and spirometry, and training in their use to be substantially scaled up in LMIC. Chapter 2: Assessment of asthma in adult, adolescent, and children 6 until 11 years. Key point: asthma control. The level of asthma control is the extent to which the features of asthma can be observed in the patient or have been reduced or removed by treatment. Asthma control is assessed in two domains: symptom control and risk of adverse outcomes. Poor symptom control is burdensome to patient and increases the risk of exacerbation, but patients with good symptom control can still have severe exacerbations. Asthma severity. The current definition of asthma severity is based on retrospective assessment after at least 2 to 3 months of asthma treatment from the intensity of treatment required to control symptom and exacerbation. This definition is clinically useful for severe asthma as it identifies patients whose asthma is relatively refractory to high-intensity treatment with high-dose inhaled corticosteroid and a long-acting beta-2 agonist and who may benefit from additional treatments such as biologic therapy. It is important to distinguish between severe asthma and asthma that is uncontrolled due to modifiable factors such as incorrect inhaled technique and or poor adherence. However, the retrospective definition of mild asthma as easy to treat is less useful, as patients with few interval symptoms can have exacerbation triggered by external factors such as viral infections or allergen exposure, and the treatment that was historically regarded as the lowest intensity short-acting beta-2 agonist alone actually increased the risk of exacerbation. Mild asthma is a retrospective label, so it cannot be used to decide which patients are suitable to receive step 1 or step 2 treatment. In clinical practice and in the general community, the term mild asthma is often used to mean infrequent or mild symptoms, and it is often assumed that these patients are not at risk and do not need ICS containing treatment. For these reasons, GINA suggests that the term mild asthma should generally be avoided in clinical practice if possible, or if used qualified with a reminder that patients with infrequent symptoms can still have severe or fatal exacerbation, and that this risk is substantially reduced with ICS containing treatment. GINA is continuing to engage in stakeholder discussion about the definition of mild asthma to obtain agreement about the implication for clinical practice and clinical research of the changes in knowledge about asthma pathophysiology and treatment since the current definition of asthma severity was published. How to assess a patient's asthma? Assess symptoms control from the frequency of daytime and nighttime asthma symptoms, night waking, and activity limitation. And for patients using SABA reliever, the frequency of SABA use. Other tools for assessing recent symptom control include asthma control test and asthma control questionnaire. There are no validated tools for assessing symptom control over a longer period. Also, separately assess the patient's risk factors for exacerbation, even if their symptom control is good. Risk factors of exacerbation that are independent of symptom control include not only a history of more than equal to one exacerbation in the previous years, but also SABA-only treatment without any ICS, overuse of SABA, socioeconomic problems, poor adherence, incorrect inhaler technique, low forced expiratory volume in 1 second, exposure such as asthma, smoking, and blood eosinophilia. To date, there are no suitable composite tools for assessing exacerbation risk. Also, assess risk factors for persistent airflow limitation and medication side effects, including from oral corticosteroid treatment, issues such as inhaler technique and adherence and comorbidities, and ask the patient or caregiver about their asthma goal and treatment preference. Once the diagnosis of asthma has been made, the main role of lung function testing is in the assessment of future risk. It should be recorded at diagnosis 3 until 6 months after starting treatment and periodically thereafter. Investigate for impaired perception of bronchoconstriction if there are few symptoms but low lung function, and investigate for alternative diagnosis if there are frequent symptoms despite good lung function. Overview. The long-term goal of asthma treatment is to achieve the best possible long-term outcomes for the patient. For every patient, assessment of asthma should include the assessment of asthma control, both symptom control and future risk of adverse outcomes, treatment issues, particularly inhaler technique and adherence, and any comorbidities that could contribute to symptom burden and poor quality of life. Lung function, particularly FEV1 as a percentage of predicted value, is an important part of the assessment of future risks. The use of digital technology, telemedicine, and telehealthcare in the monitoring of patients with asthma is rapidly increasing, particularly during the COVID-19 pandemic. However, the types of interactions are diverse, and high-quality studies are needed to evaluate their utility and effectiveness. Summary of assessment of asthma in adolescent, and children 6 until 11 years. Assess asthma control or symptom control and future risk of adverse outcomes. Assess symptom control over the last 4 weeks or longer. Identify any other risk factor for exacerbation, persistent airflow limitation, or side effects. Measure lung function at diagnosis or start of treatment. 3 to 6 months after starting ICS containing treatment, then periodically um, at least once every 1 to 2 years, but more often in at-risk patients and those with severe asthma. Second, assess treatment issues. Document the patient's current treatment step. Watch inhaler technique, assess adherence and side effects. Check that the patient has a written asthma action plan. Ask about the patient's attitudes and goals of their asthma and medication. Assess multimorbidity, rhinitis, rhinosinusitis, gastroesophageal reflux, obesity, obstructive sleep apnea. Depression and anxiety can contribute to symptoms and poor quality of life, and sometimes to poor asthma control. What is meant by asthma control? The level of asthma control is the extent to which the manifestations of asthma can be observed in the patient, or have been reduced or removed by treatment. It is determined by the interaction between the patient's genetic background, underlying disease process, the treatment that they are taking, environment, and psychosocial factors. Asthma control has two domains: symptom control and future risk of adverse outcomes. Both should always be assessed. Lung function is an important part of the assessment of future risk. It should be measured at the start of treatment, after 3 until 6 months of treatment to identify the patient's personal best, and periodically thereafter for ongoing risk assessment. GINA assessment of asthma control at clinical visits in adults, adolescents, and children 6 until 11 years. Recent asthma symptom control, but also ask the patient or caregiver about the whole period since last review. There is one question, like in the past 4 weeks, has the patient had daytime asthma symptom more than twice or week? Any night waking due to asthma, severely for symptom more than twice per week? Any activation limitation due to asthma? And there is a yes and no checklist box. And if none of this, then it is said as well controlled. But if there is one until two of this, then it is partly controlled. And if three until four of this question is yes, then it is uncontrolled. B. Risk factors for post-asthma outcomes. Assess risk factors at diagnosis and periodically, particularly for patients experiencing exacerbation. Measure FEV1 at start of treatment. After 3 until 6 months of ICS containing treatment to record the patient's personal baseline function, then periodically for ongoing risk assessment. Risk factor for exacerbation. Uncontrolled asthma symptoms. Having uncontrolled symptoms is an important risk factor for exacerbation. Factors that increase the risk of exacerbation even if the patient has few asthma symptoms. SABA overuse. High SABA use more than equal to 3 multiplied 200 dose canister per year associated with increased risk of exacerbation, increased mortality particularly if more than equal to 1 canister per month. Inadequate ICS, not prescribed ICS, poor adherence, or incorrect inhaled technique. Other medical conditions like obesity, chronic rhinosinusitis, GERD, confirmed food allergy, pregnancy, exposures like smoking, e-cigarette, allergen exposure if sensitized, and air pollution, psychosocial, major psychological or socioeconomic problems, lung function, low FEV1, especially less than 60% predicted, high bronchodilator responsiveness, type 2 inflammatory markers, higher blood eosinophils, high FANO, adults with allergic asthma on ICS, exacerbation history, ever intubated or in intensive care unit for asthma, more than equal to one severe exacerbation in last year. B. Risk factors for developing persistent airflow limitation. History, preterm birth, low birth weight, and greater infant weight gain, chronic mucus hypersecretion, medication, lack of ICS treatment in patient with history of severe exacerbation, exposures, tobacco smoke, noxious chemicals, occupational or domestic exposure, investigation finding, low initial FEV1, sputum or blood eosinophilia. Risk factors for medication side effect. Systemic frequent ICS, long-term, high-dose and or potent ICS, P450 inhibitor, local, high-dose or potent ICS, poor inhaler technique. Mm, How to describe a patient's asthma control? Asthma control should be described in terms of both symptoms control and futurist domain. For example, Miss X has good asthma symptom control, but she is at increased risk of future exacerbation because she has had a severe exacerbation within the last year. Mr. Y has poor asthma symptom control. He also has several additional risk factors for future exacerbation, including low lung function, current smoking, and poor medication adherence. What does the term asthma control mean to patient? Many studies describe discordance between the patient's and health provider's assessment of the patient level of asthma control. This does not necessarily mean that patient overestimate the level of control or underestimate its severity, but that patient understand and use the word control differently from health professional. For example, based on how quickly their symptom resolve when they take reliever medication. If the term asthma control is used with patients, the meaning should always be explained. Assessing asthma symptom control. Asthma symptoms such as wheeze, chest tightness, shortness of breath, and cough typically vary in frequency and intensity and contribute to the burden of asthma for the patient. Poor symptom control is also strongly associated with an increased risk of asthma exacerbation. Asthma symptom control should be assessed at every opportunity, including during routine prescribing or dispensing. Directed questioning is important as the frequency or severity of symptoms that patients regard as unacceptable or bothersome may vary from current recommendation about the goals of asthma treatment and may differ from patient to patient. For example, despite having low lung function, a person with a sedentary lifestyle may not experience bothersome symptoms and so may appear to have good symptom control. To assess recent symptom control, ask about the following in the past 4 weeks: frequency of asthma symptoms, days per week, any night waking due to asthma or limitation of activity, and for patient using a SABA reliever, frequency of its use for relief of symptoms. In general, do not include reliever taken before exercise because some people take this routinely without knowing whether they need it. Frequency of reliever use. Historically, frequency of SABA reliever use less than 2 or more than equal to 2 days per week has been included in the composite assessment of symptom control. This distinction was arbitrary based on the assumption that if SABA was used on more than 2 days in a week, the patient needed to start maintenance ICS containing therapy or increase the dose. In addition, higher average use of SABA over a year is associated with a higher risk of severe exacerbations, and in the shorter term, increasing use of as needed SABA is associated with an increased likelihood of a severe exacerbation in subsequent days or weeks. However, where patients prescribed an anti-inflammatory reliever as needed low-dose ICS formoterol, use of this reliever more than 2 days per week is already providing additional ICS therapy, so further dose escalation may not be needed. In addition, increasing use of as needed ICS formoterol is associated with a significantly lower risk of severe exacerbation in frequent days or weeks compared with if the reliever is SABA or compared with if the patient is using SABA alone. For these reasons, while the assessment of symptom control includes a criterion for SABA reliever use on less than equal to 2 versus or more than 2 days per week, it does not include a similar criterion for an anti-inflammatory reliever such as needed ICS formoterol. However, the patient's average frequency of as needed ICS for material use over the past 4 weeks should be assessed and considered when the patient maintenance ICS dose or need for maintenance ICS for material is relieved. This issue will be reviewed again when more data become available. Tool for assessing recent asthma symptom control in adults and adolescents. Simple screening tool. This can be used in primary care to quickly identify patients who need more detailed assessment. Examples include the consensus-based GINA symptom control tool. This classification correlates with assessment made using numerical asthma control scores. It can be used together with a risk assessment to guide treatment decision. Another example are the primary care asthma control screening tool and the 30-second asthma test, which also includes time off work or school. Categorical symptom control tools. For example, the consensus-based Royal College of Physicians 3-question tool, which asks about difficulty sleeping, daytime symptoms, and activity limitation due to asthma in the previous months. The asthma upgrade tool includes a patient-completed asthma control assessment covering 5 domains: activity limitation, daytime and nighttime symptom frequency based on US criteria for frequency of night waking, triggers adherence and patient receive response to treatment. This assessment is linked to a care algorithm for identifying problems and adjusting treatment up or down. A study in the US showed that introduction of the asthma adverse tools for patients aged 5 until 45 years in primary care was associated with improved rates of asthma control, reduced asthma-related urgent care, and hospital visits, and increased practice adherence to asthma management guidelines. Numerical asthma control tools. These tools provide scores and cut points to distinguish different levels of symptom control validated against healthcare provider assessment. Many translations are available. The scores may be useful for assessing patient progress. They are commonly used in clinical research but may be subject to copyright restriction. Numerical asthma control tools are more sensitive to change in symptom control than categorical tools. Examples of numerical asthma control tools for assessing recent symptom control are Asthma Control Questionnaire, score range from 0 to 6, higher is worse, with scores calculated as the average from all questions. The author stated that AZK more or less than equal to 0.75 indicated the high probability that asthma was well controlled. 0.75 until 1.5 as a gray zone and more than equal to 1.5 a high probability that asthma was poorly controlled based on concept of asthma control at the time. The latter added that the crossover point between well-controlled and not well-controlled asthma was close to 1. The 5-item ACQ comprises 5 symptom questions. Two additional versions were published. ACQ 6 includes subar frequency and ACQ 7 also includes pre-bronchodilator FEV1 percentage predicted. The minimum clinically important difference for all three versions of ACQ is 0.5. GINA prefers ACQ 5 over ACQ 6 or 7 because the liver question assumes regular rather than as needed use of SABA. There is no option between zero SABA use in a week and SABA use every day, and ACK has not been validated with ICS formoterol or ICS SABA as the reliever. In addition, if ACK7 were to be used in adjustment of treatment, the inclusion of FEV1 in the composite score could lead to repeated step-up in ICS dose for patients with persistent airflow limitation. For these reasons, data for ACQ5, ACQ6, and ACQ7 cannot be combined for meta-analysis. Asthma control test scores range from 5 until 25, higher is better. Scores of 20 until 25 are classified as well controlled, 16 until 19 as not well controlled, and 5 to 15 as very poorly controlled asthma. The ACT has 4 symptom or reliever question plus patient self-assess control. The minimum clinically important difference is 3 points. It has not been validated with ICS full material or ICS SABA reliever. Patients with good symptoms control can still be at risk of future severe exacerbation or asthma-related death, and there are many modifiable risk factors for exacerbation that are independent of symptom control. So, GINA does not recommend assessment tools that combine symptom control with exacerbation history. When different tools are used for assessing asthma symptom control, the results correlate broadly with each other, but are not identical. Respiratory symptoms may be non-specific, so when assessing change in symptom control, it is important to clarify that symptoms are due to asthma. Recent symptom control can be assessed over the previous 1 to 4 weeks using tools such as GINA, Box2, or ACKV5 or ACT. There are no validated tools for assessing asthma symptom control over a longer period like for 12 months. In clinical practice, the patient can be asked about previous months with a simple question, but there is likely to be substantial recall error, particularly for mild symptoms. Box 2-3, specific question for assessment of asthma in children 6 until 11 years. Asthma symptom control. Day symptom. Ask how often does the child have cough, wheeze, deep snow, or heavy breathing, number or times per week or day? What triggers the symptoms? How are the symptoms managed? Night symptoms. Cough awakening, tiredness during the day. If the only symptom is nocturnal cough, consider other diagnoses such as rhinitis or gastroesophageal reflux disease. Reliever use. How often is reliever medication used? Check date on inhaler or last prescription. Distinguish between pre-exercise use, sports, and use for relief of symptoms. Level of activity. What sports or hobbies interest? Just the child have. school and in their spare time? How does the child's level of activity compare with their peers or siblings? How many days is the child absent from school? Try to get an accurate picture of the child's day from the child without interruption from the parent or caregiver. Risk factors for adverse outcomes. Exacerbation. Ask, how do viral infection affect the child asthma? Do symptoms interfere with school or sports? How long does the symptom last? How many episodes have occurred since their last medical review? Any urgent doctor or emergency department visits? Is there a written action plan? Risk factors for exacerbation include a history of exacerbation, poor symptom control, poor adherence and poverty, and persistent bronchodilatory reversibility even if the child has few symptoms. Lung function checks, spirogram curves, and technique. Main focus is on FEV1 and FEV1 per FVC ratio. Plot these values as percent predicted to see trends over time. Side effects. Check the child's height at least yearly, as poorly controlled asthma can affect growth, and growth velocity may be lower in the first 1 until 2 years of ICS treatment. Ask about frequency and dose of ICS and OCS. Treatment factors. Inhaler technique. Ask the child to show how they use their inhaler. Compare with a device-specific checklist. Adherence. Is there any of the child prescribed maintenance medication like inhaler and or tablets in the home at present? On how many days in a week does the child use it? For example, 0 to 4, 7 days. Is it easier to remember to use it in the morning or evening? Where is the medication kept? Is it in plain view to reduce forgetting? Check date on inhaler. Goals or concerns. Does the child or their parent or caregiver have any concern about their asthma? For example, fear of medication, side effects, interference with activity. What are their goals for treatment? Comorbidities. Allergic rhinitis, itching, sneezing, nasal obstruction. Can the child breathe through their nose? What medication are being taken for nasal symptoms? Eczema, sleep disturbance, topical corticosteroid, food allergy. Is the child allergic to any foods? Confirmed food allergy is a risk factor for asthma-related death. Obesity, check age-adjusted BMI. Ask about diet and physical activity. Other investigation if needed. 2-week diary. If no clear assessment can be made based on the above question, ask the child or parent or caregiver to keep a daily diary of asthma symptoms, reliever use, and peak expiratory flow based of 3 for 2 weeks. Formal exercise challenge provides information about airway hyperresponsiveness and fitness. Only perform challenge testing if it is otherwise difficult to assess asthma control. Tools for assessing recent asthma symptoms control for children aged 6 until 11 years. In children, as an adult, assessment of asthma symptom control is based on symptoms, limitation of activities, and use of rescue medication. Careful review of the impact of asthma on a child's daily activity, including sports, play, and social life, and on school absenteeism, is important. Many children with poorly controlled asthma avoid strenuous exercise, so their asthma may appear to be well controlled. This may lead to poor fitness and a high risk of obesity. Children vary considerably in the degree of airflow limitation observed before they complain of dyspnea or use their reliever therapy, and marked reduction in lung function is often seen before it is recognized by the parent or caregiver. They may report irritability, tiredness, and change in mood in their child as the main problems when the child asthma is not controlled. Parents or caregivers have a longer call record period than children, who may recall only the last few days. Therefore, it is important to include information from both the parent or caregiver and the child when the level of symptoms control is being assessed. Several numerical tools have been developed for assessing recent asthma symptom control for children. These include childhood asthma control tests with separate section for parent or caregiver and child to complete. Asthma control questionnaire. Some asthma control scores for children include history of exacerbation with symptoms, but this may have the same limitation as described above for adults. They include tests for respiratory and asthma control in kids and the composite asthma severity index. The result of these various tests correlate to some extent with each other and with the GINA classification of symptom control. Assessing future risks of exacerbation, lung function decline, and adverse effects. The second component of assessing asthma control is to identify whether the patient is at risk of adverse asthma outcomes, particularly exacerbation, persistent airflow limitation, and side effects of medication. Asthma symptoms, although an important outcome for patients and themselves, a strong predictor for future risk of exacerbation, are not sufficient on their own for assessing asthma for severe reasons. Asthma symptoms can be controlled by placebo or sham treatments or by inappropriate use of short-acting SABA or long-acting beta-2 agonists alone, all of which leave airway inflammation untreated. Respiratory symptoms may be due to other conditions such as lack of fitness or comorbidities such as inducible laryngeal obstruction. Anxiety or depression may contribute to higher symptom reporting. Some patients have impaired perception of bronchoconstriction with few symptoms despite low lung function. In patients with good symptom control, exacerbations can be triggered by environmental exposure, such as viral infection, allergen exposure, and poor air quality. Asthma symptom control and exacerbation rates should not be simply compared numerically, as poor control of symptom and of exacerbation may have different causes and may need different treatment approach. Risk factors for exacerbation. Poor asthma symptom control itself substantially increases the risk of exacerbation. However, several additional independent risk factors have been identified. For example, factors that when present increases the patient risk of exacerbation even if symptoms are few. These risk factors include a history of more than equal to one exacerbation in the previous year, poor adherence, incorrect inhaler technique, chronic sinusitis, and smoking, all of which can be assessed in primary care. The risk of severe exacerbation and mortality increases incrementally with higher SABA use, independent of treatment step. Prescribing of 3 or more 200 dose SABA inhaler in a year, corresponding to more than daily use, is associated with an increased risk of severe exacerbation, and in one study, increased mortality. Risk factors and comorbidities that are modifiable or potentially modifiable are sometimes called treatable traits. In children, the risk of exacerbation is greatly increased if there is a history of previous exacerbation. It is also increased with poor symptom control, suboptimal drug regimen, comorbid allergic disease, and poverty. Risk factor for developing of persistent airflow limitation. The average rate of decline in FEV1 in non-smoking healthy adults is 15 until 20 milli per year. People with asthma may have an accelerated decline in lung function and develop airway limitation that is not fully reversible. This is often associated with more persistent dyspnea. Independent risk factors that have been identified for persistent airflow limitation include exposure to cigarette smoke or noxious agents, chronic mucus hypersecretion, and asthma exacerbation in patients not taking ICS. Children with persistent asthma may have reduced growth in lung function, and some are at risk of accelerated decline. There is no clear evidence that treatment with ICS prevents accelerated decline in post-bronchodilator lung function, for example, that it prevents development of persistent airflow limitation. Risk factors for medication side effects. Choices with any medication are based on the balance of benefit and risk. Most people using asthma medications do not experience any side effects. The risk of side effects increases with higher dose of medication, but these are needed in few patients. Systemic side effects that may be seen with long-term high-dose ICS include easy bruising, an increase beyond the usual age-related risk of osteoporosis and fragility fractures, cataracts, glaucoma, and adrenal suppression. Local side effects of ICS include oral candidiasis and dysphonia. Patients are at a great risk of ICS side effects with higher doses or more potent formulations, and for local side effects with incorrect inhaler technique. A glossary of asthma medication has been added as an appendix at the end of this report. Drug interaction with asthma medication. Concomitant treatment with cytochrome P450 inhibitors such as ketoconazole, ritonavir, itraconazole, etromycin, and clarithromycin may increase the risk of ACS adverse effects such as adrenal suppression, and with short-term use may increase the risk of cardiovascular adverse effects of dilabus, salmeterol, and vilanterol, alone or in combination with ICS. Concomitant use of this medication is not recommended. Oke, sampai situ dulu episode 2. Kita lanjut halaman selanjutnya di episode 3. Terima kasih.